Hello, cardiac anatomy. Is that okay? Because I am skipping right now the embryology part.
Okay, that's
So if we can start with the cardiovascular anatomy, then this is a good, perfect, and final view of the heart system. So heart is anatomically placed in the mediastinum. So this is an important concept to consider when you are discussing the anatomy of the chest. You have to think about what is mediastinum. So what is mediastinum?
the middle bone of the chest that connects all the ribs.
Uh, I don't know. I am not listening your voice very clearly. I think you are not using hands-free, maybe.
No, I'm just saying it's the middle bone of the chest that connects the ribs together.
Mediastinum, Dr. Ali, any input from your side? What is mediastinum of the chest?
I think it's like the area behind the chest, right? Between
Okay,
the lung. I'm not sure.
okay. So mediastinum is actually the middle part of the chest. Okay, so
Okay.
this is the middle part of the chest, and this is the mediastinum.
Okay.
What is mediastinum? Between the two lungs, there is an area in the chest that is called the middle part of the chest, and that is the definition of mediastinum. Okay, so the mediastinum has three areas. The mediastinum is divided into three parts, and which thing is dividing the mediastinum? It's the heart itself. So heart is sitting in the mediastinum in the middle of the chest, right behind the sternum. Okay, so heart is dividing that middle part of the chest into three parts. The area where the heart itself is located is called the middle mediastinum. The area that is in front of the heart and behind the sternum is called the anterior mediastinum. And the area that is present behind the heart and in front of the vertebral column is called the posterior mediastinum. Is that okay?
What is the heart
So
considered? That's just called
Middle.
middle. Okay.
middle, that is called the middle mediastinum. So remember that what is the mediastinum? Mediastinum is the whole space that is between the sternum and the vertebral column between the two lungs. The lungs are not a part of mediastinum. Remember this thing. Lungs are the part of pleural cavity. Okay? So lungs are present within the pleural cavity, and mediastinum, do not confuse the mediastinum with the pleural cavity. So these are the lungs that are present on the sides, and they are part of the pleural cavity. And all other structures that are present within the center of the chest, they are actually the parts of the mediastinum. So mediastinum is basically divided into two parts. The one part is the superior mediastinum, and the other one is the inferior mediastinum. So superior mediastinum is the part of the middle part of the chest that is above the heart. Okay? The mediastinum is divided into two parts. One is the superior mediastinum and the one is the inferior mediastinum. The superior mediastinum is the part of the chest, middle part of the chest that is above the heart, as you can see in this picture. Just focus on this picture right now. So this is the superior mediastinum, and where the heart starts, that becomes the inferior mediastinum. And now the inferior mediastinum is further divided by the presence of heart in three areas. The one is the anterior mediastinum, as we discussed, then the middle mediastinum, and the posterior mediastinum. Everything okay? So what is that vertebral level where the superior and the inferior mediastinum are getting connected? That is the T4 level. So sometimes they give you some X-ray on your exam, and they give you the slice of the. So tell me if you can see the heart in your CT scan slice. So what do you think the slice level of this CT scan should be above the T4 level or below the T4 level?
Below.
Below the T4 level. Okay, so that's how they can design a question for you. They will give you T1, T2, T3, T4, T5. So if you can see the heart, it technically means that you are at below the T4 level. And then then you may ask what are the various contents of the mediastinum. That's also very important. Even the first line that you are seeing in this first state is technically linked to the mediastinum. So that's why I'm focusing on this picture. So what are the various components of the anterior mediastinum, posterior mediastinum, and the middle mediastinum? So as we discussed, that middle mediastinum is composed of heart and the lining of the heart. In front of the heart we have a thymus, that is the most important thing, and just behind the heart we have esophagus, descending aorta, thoracic duct, and the sympathetic. Very high. If you want to know many of the diseases, you have to learn the mediastinum. Any confusion till now about the what is inferior mediastinum? It's the mediastinum just below the T4 level where the heart is present. And due to the presence of heart, the things that are in front of the heart, they are the part of anterior mediastinum. The heart itself is present in the middle of the mediastinum. And just behind the heart, there are many important structures crossing through the chest and entering into the abdominal cavity, and maybe coming from the abdominal cavity into the chest. And that is the posterior mediastinum. And look at here. The first line they are telling you is that the left atrium is the most posterior part of the heart. And as we just discussed, what structure is present behind the heart? That is the esophagus. And the most posterior structure of the heart is the left atrium. If due to some problem, the left atrium is enlarged, it can cause dysphagia. That is called the cardiovascular dysphagia or the cardiac dysphagia. Okay? So this line is directly linked to the anatomy of the mediastinum, and not only this, but also remember that the recurrent laryngeal nerves, when they are when they are passing through to the chest, they are looping around the left-sided recurrent laryngeal nerve loops around the arch of the aorta. And when it loops around the arch of the aorta, this enlarged left atrium can compress that left recurrent laryngeal nerve, and that can lead to the hoarseness of voice. So these are the two features of the left atrial enlargement. So similarly, if you want, okay. So we discussed that. Let me show you one picture so that you understand this in a better way. So this is the lateral view of the heart, and we can clearly see that the vertebral column is visible, and this is the contrast that we have entered into this, and that contrast is
Hold on. We can't hear you.
I think it's the internet.
Yeah.
cavity,
Hold on.
and you can clearly see a dent that is being put
Hold on 1 second. Hold on. I think I'm gonna.
because of large. Hello.
I think I'm gonna have to reconnect. Just give me 1 second. I couldn't hear.
Okay.
Yeah, let me
We're
just.
Okay.
breaking
No
up.
problem. यार अब बोलो कुछ ना नेट नहीं यूज कर
Connected. Okay. All right, we're good. Okay. So you were explaining. Sorry.
Hello.
So you were just explaining the contrast is in the esophagus.
Oh yes, it's the contrast is in the esophagus, and you can clearly see that it is going downwards towards the abdomen, and you can see that there is a backward push on the esophagus, and remember that the most posterior part of the heart, that is almost in front of the esophagus, is the left atrium. Okay, and when this left atrium, due to some enlargement, like in the mitral stenosis, this left atrium can get enlarged, so that can lead to compression on the esophagus and will give you some dysphagia. That is called the cardiogenic dysphagia. They often ask you this question. I don't know why I took a picture of the recurrent laryngeal and I am not seeing that picture here. Okay, I will show you later on that how the hoarseness is going on due to the why. Just remember that left recurrent laryngeal nerve is winding around the arch of aorta, and arch of aorta is just above the left atrium. So
Right.
if the left atrium is getting enlarged, that left recurrent laryngeal nerve can be compressed between this enlarged left atrium and the arch of aorta. So just remember that due to this mechanism, the hoarseness is going on. Now, another important and very, very extremely high yield concept for the exam purposes is that you have to look at into the heart exactly how the outer surfaces of the heart are being made. So this is the anterior view of the heart, and you can see that there is a fatty layer in the on the anterior surface of the heart, and remember that this fatty layer is actually dividing the right ventricle and the left ventricle on this side. So tell me, the anterior surface. This is the anterior surface of the heart. This is the anterior surface of the heart. So anterior surface is made of mainly which ventricle? Right ventricle or the left ventricle?
Right.
Hello? Right
Right.
ventricle. Okay, why? Because this is the groove that is separating the right ventricle from the left ventricle, and we can clearly see that the right ventricle is mainly making the anterior surface of the heart. Another important thing is that this is the right border of the heart, and right border of the heart you can clearly see is made by this right atrium. And now, if you go to the diaphragmatic first surface, that is the surface that rests on the diaphragm. And then let me tell you that this surface is mainly made by the left ventricle. Okay, so these are some of the important things. Diaphragmatic surface is less high yield, but the more high yield thing is here. If you see the surface of the heart in comparison to how the sternum is placed in front of the heart, then this is the picture. And one of the questions they ask you is that if a person has a stab wound just towards the right side of the sternum, which structure is going to be damaged? So remember that this is the right atrium that we can clearly see. So if the patient has, if you just correlate this picture with this picture that I just showed you, so this is the area that just comes to the right side of the sternum, okay? And we are seeing this area in this picture. So this area is the right atrium, and right atrium is just coming towards the right side of the sternum. And if a patient has stab wound just towards the right side of the sternum, so the most likely area to get damaged is the right atrium. But remember that as most of the other anterior surface is made by the right ventricle, the most common area to get damage during the chest trauma is the right ventricle, and that is associated with the anatomical concept. So right ventricle forms the anterior surface of the heart, and that is injured most commonly in the trauma. So what is pericardium? If you focus on this picture, that it clarifies almost everything about the pericardium, that this is the heart, and if you cut out some of the surface and see what's going on here, then you see a fibrous tissue on the outermost surface that is called the fibrous pericardium. And then on the inside of the fibrous pericardium, we see another two layers, and these are actually the serous pericardium reflected onto itself at the margins of the heart, and by reflecting onto itself, it is giving rise to two layers of the heart. The layer that is closely attached to the myocardium of the heart is called the visceral layer of the serous pericardium, and the layer that reflects at the margins of the heart and then again goes along with the surface of the heart and makes a gap between the visceral pericardium, that layer is called the parietal layer of the serous pericardium. So it's actually the same layer, the serous pericardium, and that is reflecting onto the surface of the heart under the fibrous pericardium. And by just this reflection, it is giving rise to a very important cavity called the pericardial cavity. Lots and lots of pathology due to this pericardial space, as well as the whole structure, the pericardium. Any confusion in the layers of the pericardium?
No.
No, okay. So now the next thing is that you have to look very seriously that what's going on around the pericardium, because that's very important. So if you focus around the pericardium, then a nerve, very important nerve, is crossing over the pericardium and going downwards to supply the domes of the diaphragm. So this is the pericardium green structure, and these are the two yellow structures on the periphery of the pericardium. These are the left and right phrenic nerves, and phrenic is the nerve for the diaphragm. Okay. So if due to some problem, if due to some diaphragmatic irritation or due to acute pericarditis, maybe the phrenic nerve will get irritated. So if this phrenic nerve is getting irritated, then there is the one very common question they ask you on the exam is that why the patient is suffering from the pain around the shoulder. Okay. So if due to some hernia that is passing through the diaphragm that is irritating the diaphragm, or if due to acute cholecystitis, why? Because the gallbladder is just below the diaphragm. If the gallbladder becomes inflamed, that can irritate the that can irritate the phrenic nerve that is supplying the diaphragm. Similarly, the acute pericarditis can irritate the phrenic nerve. Why? Because it is lying. This phrenic nerve is lying over the acute over the pericardium. So remember that the roots of the spinal cord, from where the phrenic nerve is arising out, the same roots gives rise to the nerves that supply the shoulder region. Okay. So due to this, okay.
You said irritation of the phrenic nerve, right? So this can happen through two different ways. One, it can be if there's an irritation from the cardiac, right? From
Pericardium.
and the other one is from cholecystitis.
Yeah,
Diaphragmatic irritation. Any cause of even the patient with pneumopericardium means air within the pneumoperitoneum means the air within the abdominal cavity or some viscous perforation in the abdomen and gastric fluid and other intestinal fluids are entering into the peritoneal cavity. So remember that that may also irritate. So diaphragmatic irritation due to any cause, either pneumoperitoneum, either due to peritonitis, either due to acute cholecystitis or hepatitis, or maybe this hernia. This is the example of hernia that is trying to push through the diaphragm and enter into the. So remember that any sort of these two areas, that the pericardial area and the diaphragmatic area, whenever they are irritated, they send the irritative signals back to these roots of the spinal cord. But there is one concern here that the nerves that come out of the spinal cord and supply the region of the shoulder, they are also coming out from the same roots. So that why the irritative signals of the phrenic nerve can produce referred pain over the shoulder. That's very high here. That's very high. If you see irritation of the shoulder and the pathology is in the chest and the pathology is in the abdomen. If the pathology is in the chest, you know that the pathology has something to do with the pericardium. And if the pathology means the acute abdomen patients is also complaining of the pain around the shoulder. So we know that something is very close to the diaphragm. Either it is air, either it is acute cholecystitis, either it is some fluid touching some fluid that has arrived came out of the perforated small bowel and is irritating the diaphragm. So that's how we get an indication that something is touching the diaphragm. So that's how we think about it. So it compose nothing else. You may read it and everything is clear here. So one more thing is the very super high yield topic is the coronary blood supply. What do you know about the coronary blood supply already? So this is the picture here.
Left main coronary artery is the main one, dominant.
Okay.
The most common that is occluded is left anterior descending.
Very good. Very good.
And
Okay.
It has three branches, right? So you have the left anterior, then you have circumflex,
right,
and then you have the marginal, the left marginal.
and then the posterior descending is a like loop around of the left acer. Yeah, like left
Oh,
is
yeah.
and loop and goes towards the posterior.
Okay.
And then I believe they both anastomosis in the back, right? Posterior heart.
Okay.
Okay.
Okay. Okay. Okay, let's talk about in a systematic way. Just like the nature has given you the left and the right heart, similarly, your blood supply is left and right heart. Okay. So left system, there is a left system composed of the right coronary artery, and there is a right system arising from the right coronary artery and the left coronary artery. So remember that these are the only two branches that arise from the ascending aorta. There is no other branch of the ascending aorta. One important thing.
Okay.
The second important thing is that if due to some you want to put a stent into these two arteries, what is the only portal through which you enter into these arteries?
Aorta.
Through the aorta. Okay, so that's why we have to come into the aorta and then reach the base of the aorta just close to the heart where the coronary arteries are entering. That's why we catheterize through the radial artery or the femoral artery. So we come all the way back to the aorta and then we put our catheter into these vessels, and then that catheter may help us to put a stent in those arteries. Very good. So that's how we think about it. Now the next thing is that the right coronary artery, its branches are less important. The only important thing about the right coronary artery is related to the dominance of the heart. So when we talk about the left system, oh sorry, the right system and the left system, we also describe about which system is dominant. Either it is the right system is dominant or the left system is dominant. So we have decided one thing. We have decided one thing is that whichever artery will supply the PDA, we will make that artery the dominant system of the heart. So what we have seen in our population is that majority of the population is getting the blood supply in the PDA through the right coronary artery. So that's why majority of the population is the right dominant. What does the right dominant means? People don't know what does the dominance means. So remember that dominance is the concept that describes which artery is feeding the posterior descending artery. We don't consider PDA as a very distinct branch of either it is a branch of left coronary artery or right coronary artery. We describe this vessel in such a way which vessel is supplying the PDA. Either it is the right coronary artery supplying the PDA and left coronary artery supplying the PDA. As I told you, the branches of the right coronary artery are less high. The more high yield thing regarding the right coronary artery is that it is the one that most commonly supplies the PDA and makes the right coronary artery the dominant artery of the heart. That's very important. Okay?
I was always under the impression that the dominant artery would be the one that's supplying the SA and the AV node.
No, no, no. That's totally and totally wrong. Okay, I will tell you that PDA is the one that supplies the AV node. Okay, and that's why the blood supply of the AV node is variable. It depends on which artery is dominant. Most commonly, it's the right coronary artery. But if the left coronary artery is supplying the PDA, then the blood vessel of the blood supply of the AV node is coming from the left coronary artery. Okay. If the left coronary artery is supplying the PDA, the artery, as we know that PDA supplies the AV node, then and if the PDA is getting blood supply from the left coronary artery, then remember that the blood supply of the AV node is coming from the left coronary artery. Remember this thing. PDA supplies the AV node. Remember this thing. PDA supplies the AV node, and whichever artery, either it is right coronary artery or left coronary artery, whichever artery supplies the PDA, that system of the heart will be dominant.
What
It's
determines
not okay.
is there some kind of what do you call disease or some kind of a different thing that makes the right coronary artery the dominant instead of the left coronary artery?
No, no, no. It's just the like look, if we catheterize my heart and if they see that my PDA is being supplied by the right coronary artery, then I am a right dominant person.
No, but what determines if a person becomes a right coronary? Is there a consensus as to one thing that makes someone right coronary artery like dominant instead of left?
Oh, this is the embryological. This is the embryological development of the heart. If the heart of some patient, if the heart of some person is getting in such a way that its posterior descending artery is supplied by the right coronary artery, it will become a right dominant person. That's what we know. It's not a disease that is leading to the right dominance or left dominance. It's the normal anatomy of the heart.
Okay, okay, okay.
Okay, when we are building our heart, if during that building process the posterior descending artery gets blood supply from the right coronary artery, that will become a right dominant circulation. And if the posterior descending artery is getting blood supply from the if you want to say visualize this, let me show you. So dominance is defined as the artery that supplies the posterior descending artery. Okay. So in this picture, they tried to make that this pink system means the right system is supplying the posterior descending artery. This is the posterior descending artery. And in this picture, they tried to show you that this reddish system is trying to supply the posterior descending artery. So dominance is right if the descending right coronary artery supplies the PDA, and dominance is left if the left coronary artery supplies the PDA. Simple is that, and that has nothing to do with any disease. That has to do with the embryology of the heart. Means when the heart is developed, if the heart PDA vessel gets blood supply from the right coronary artery, it's the right dominant heart, and if it gets from the left coronary artery, it's the left dominant heart. Simple. Dominance has nothing to do with the disease. No disease can change the dominance of the heart. It is decided when the person is in the embryological life, means when it is being developing its heart and the blood vessels of the heart. Any confusion?
No.
Okay, so that is an independent story. Dominance is an independent. Now come to the most common, the most important thing. And Ali bhai, you talked about the blood supply of the SA node. Remember, SA node is supplied by the right coronary artery. It's the AV node that is supplied by the PDA. So now the next thing is the left coronary artery. Its branches are very important. Why? We will see that. So left coronary artery is supplying the left heart, and the left coronary artery has three main branches. One is the left anterior descending that runs in. One is the left anterior descending. Other one is the marginal artery, and the other one is the left circumflex iliac. Oh, sorry, left circumflex coronary artery. It rotates around the margin of the heart and goes back. Okay, and this circumflex artery is actually supplying the lateral wall of the heart. This greenish area is the lateral wall of the heart, and this circumflex artery is supplying the lateral area of the heart. So PDA, so this left anterior descending artery is running on the anterior surface of the heart, where that is very high here. So look at here. I showed you this picture before. So this is the artery. This is the vessel running in the anterior interventricular groove. What is anterior interventricular groove? Anyone knows?
Is that where basically the two septae are connecting?
Yeah.
Oh,
Doesn't it like separate the two ventricles? Like
Yeah.
there's the middle
Oh.
part.
yeah, very good. So that this is the anterior interventricular groove. Similarly, we have a posterior interventricular groove. Okay, so the anterior interventricular groove contains the left anterior descending vessels. The first branch of the left coronary artery is the LAD. So the most common artery that is occluded during the coronary vessel disease is this system that you are just seeing right now. This is the one. The left anterior descending is the one that has most atherosclerotic dilemma going on in the clinical situations. So this is the anterior interventricular groove. Remember, the PDA is the one that runs in the posterior interventricular groove. So they have also made this like this. So here, as we know that most commonly PDA gets blood supply from the right coronary artery, they are showing that the right coronary artery is ultimately supplying the PDA. So if this thing is clear, then we can discuss what are the further details regarding this. If you know all these things, then definitely it's gonna become. Now you have to remember what are the various areas the different vessels are supplying. So left anterior descending supplies the anterior two-third of the septum because this is the area of the septum. And also it supplies the anterolateral papillary muscles. So papillary muscles are very, very high here because in the sense of the when you will discuss the myocardial infarction with me and we will see the that it is the ischemia and necrosis and ultimately infarction of the heart muscle. So we have to keep in mind that is it just the wall of the heart that is getting necrosis or some papillary muscle? So papillary apparatus is a different story, and it has very important disease implication in a patient of myocardial infarction. So we have basically two papillary muscles in our left heart, and this is the anterolateral. You can clearly see the among the two. This is the number two. Let me label it number two and label it number one. So you can clearly see that the number one is anterior, means it is in front of the number two, and also it is little bit lateral to the on the lateral side. So this system is actually the anterolateral papillary muscle, anterolateral, and this one that is close to the posterior wall, and that is also close towards the midline of the heart. This is a postero or medial papillary system of the heart. And remember that if any of these two papillary muscles they get damaged, so what can happen? It is very clear in this picture.
Uh,
Well, if you're going to damage the,
you can't control the valve, right? So the blood
Yes.
won't go into the ventricle and won't go out to the aorta.
Oh, so if this papillary muscle is ruptured, then this flap of this wall will not be able. So we will not be able to close our valve. Okay. So if we will not be able to close our valve, our valve area, and that condition is called the mitral regurgitation. And remember, many of the patients who suffer from the LAD, myocardial infarction. Okay, we just discussed that LAD is the most common vessel that gets atherosclerotic dilemma in the clinical situations. So LAD is the one that supplies this anterior anterolateral papillary muscle. So if we get the LAD myocardial infarction, so this papillary muscle may get dysfunction, and patients may develop acute mitral regurgitation. You understand this point?
Got it.
Got it?
Yes.
So that's the clinical implication of analyzing which vessel is supplying the papillary muscle, because acute MR may may even more damage may happen to the patient due to this acute MR. Rather than MI, patient may die of this acute MR. Why? Because this acute MR will lead to severe pulmonary edema right away. And that severe pulmonary edema in the presence of this MI will can lead to easy death. Easy death may happen if the patient is getting acute MR due to the dysfunctional role of the anterolateral papillary muscle. That's very high. You cannot skip it. We will see it again in the mechanical complications of the myocardial infarction. So it also supplies the anterior of the interventricular septum. So we discussed it, anterolateral papillary muscle and anterior surface of the left ventricle, most commonly occluded. We discussed it. So now comes to the PDA. As we discussed, that PDA supplies the AV node, and it depends on the dominance of the heart. That's what we discussed. So
I
the
had a question.
okay, Alibai, go ahead with the question.
It was in regards to the papillary muscle. So when we say that the posterior medial papillary muscle is affected, we're going to most likely get MR, right? Mitral regurg. But if the anterior lateral papillary muscle is affected, then would we say it's going to be an issue with the aortic valve?
No, no, no.
No.
These two, remember the mitral valve is being closed anteriorly and posteriorly with the help of these two valves. You can clearly see that both valves are controlling the mitral valve.
Okay.
Single papillary muscle cannot control the whole valve. It's a circular area. So
Okay.
two valves are controlling. So any of these papillary muscles, if they get dysfunctional, then the mitral regurgitation can happen. And there is again a very important question in the blood supply of this papillary muscle. Remember, let me clarify it here that the anterolateral papillary muscle, this anterolateral papillary muscle has only one blood supply, and that is the lead.
Right.
Oh no, sorry. Anterolateral has two blood supply, and
Okay.
the posteromedial has only one blood supply, and that is the PDA. Okay, so this is the posteromedial. PM is the posteromedial, and remember that posteromedial has only one blood supply, and that is the PDA vessel. But the anterolateral has two blood supplies. One is the LAD, and the other one is another artery that you will see shortly. So that's why the posteromedial one, which valve, if this which papillary muscles are more associated with the ischemia. So which,
Post,
yes,
posterior because it only has one.
posterior, because of the one blood supply that it is getting. So PDA supplies the AV node. Okay, so let's talk about the blood supply of the nodes of the heart. So heart has two nodes. SA node is very clear. It is getting its blood supply right away from the right coronary artery. Simple. But the AV node is tricky. Why? Because it gets supply from the PDA. And PDA, we discussed that PDA can be supplied by the right coronary artery or the left coronary artery, depending upon the dominance of the heart. If the heart is right dominant, the right coronary artery is supplying the PDA. And if the heart is left dominant, then the left coronary artery will supply the PDA. So they may ask you several questions on this concept. So they may ask you, they may give you that the if a patient's AV node is getting ischemic, and it's if the patient's AV node is getting ischemic and that patient is left dominant, so tell me, from where the AV node is getting blood supply, right coronary artery or the left coronary artery?
Left coronary.
Left coronary artery. That's how they frame the question. They want to trick you. They want to trick you that whether you know that the dominance of the heart decides the blood supply of the AV node. Why? Because dominance decides from where the PDA is getting supply, and PDA ultimately supplies the AV node. So posterior one-third septum, posterior walls of the ventricles, posteromedial papillary muscle. It is supplied by the PDA, and the only blood supply of the posteromedial papillary muscle that I showed you in the picture is the PDA. So right marginal artery supplies the right ventricle low yield branch, and right coronary artery directly supplies the AC node. So it is independent of the dominance, because clear, it's clear. SA node is clear, it will get its blood supply from the right coronary artery. So infarcts may cause nodal dysfunction. If the right coronary artery is getting blocked, then remember that a bradycardia or heart block may happen. So 85% of the people, PDA arises from the right coronary artery and they are right dominant. 8% people, their PDA is being supplied by the left coronary artery. 7% are combined. Their PDA gets blood supply from left circumflex coronary and right coronary artery. And one other important thing is that the coronary blood flow peaks in the early diastole. Anyone who knows this, the answer to this? Why?
Blood supply peaks in early diastole because once the contraction happens, the blood is out. So now the heart is relaxing in diastole, but the blood just went outside aorta and it's going to supply the coronary artery. So even though the heart is in early diastole, the systole caused the blood to go to coronary artery, correct?
Okay, Alibai, you.
I was just gonna say because the heart is relaxing, it's allowing for the blood to pool into it. The heart is allowing the blood to pool into it in order to find.
Oh, yes. So just imagine this picture. So if During this systole, the blood was being pushed through the aorta, and the heart was contracting so much that all the vessels that are present close to the heart surface, they are getting compressed, and they are. But just remember that when the heart started to relax, don't you think that it will provide a suction mechanism for the blood to come into the mechanism for the blood to come into the opens up. So the blood that is in the aorta will be forced to come to this area due to that relaxation and due to that suction type of mechanism that will attract the water, attract the blood from the aorta into the coronary circulation. So the mechanism is that during the contraction, the heart is pumping out, but during that no doubt the blood has more pressure during the systole. But even under that pressure, due to the contraction of the muscle fibers, the resistance of the coronary vessels is so high that even this systolic blood pressure cannot allow the coronary blood flow to reach very high levels of blood flow. But during diastole, even though the pressure of the blood is low, diastolic pressure is low in the aorta. Okay, so even though the pressure during the diastole is low, but as the heart is relaxing and its muscle fibers are going back to the relaxed state from the contracted state, they will provide a room for the coronary vessels to open up, and that opening of the coronary vessels will provide a suction mechanism for the blood to come into the coronary circulation. That's very high. People may ask you why during this systole under very high pressure coronary arteries don't fill up, and during diastole when the blood pressure is low, the coronary circulation is going to boom boom and fill with the blood. The mechanism is that it's not the pressure problem, it's the problem is the resistance problem. During contraction, the coronary vessels are having so much resistance that even so much pressure in the aorta is unable to provide a very good amount of coronary flow. But during the diastole, the resistance is so low that even low pressure in the aorta is very good for the coronary flow to happen very smoothly. That's how we think about it. It's not just the answer is tricky, and it relates to the very basic principles of resistance and blood flow. Resistance and blood flow. We will see the equation today. So this is the coronary blood flow. It peaks in the early diastole. Any confusion till here? Very high yield topics.
Yeah.
Clear? So one more thing that I want to tell you is the is a concept of that. Remember that each area of the heart is supplied by a very specific type of artery, as you can clearly see in this area, in this region. And also each area of the heart produces specific waves, specific changes in the ECG if that area is not getting blood supply. Okay, so keeping these two things together means each area supplied by a specific vessel, and each area when it becomes ischemic, it gives rise to a very characteristic changes in specific leads of the ECG. So when we combine these two areas, there is a very nice table that you will see in the Hoover 2. But this is an area that they most often ask you. So if the inferior wall MI is happening, so remember these are the leads that will show the biggest changes. If the anterior wall is happening, these are the leads. And if you guys have difficulty recognizing this one, we can do some further lecture on this. But when so just giving you an idea that a specific artery supplies a specific area, and that area when becomes ischemic gives rise to specific changes in a specific leads. So due to this, if I see problems in the V2 to V4, I know it's the LAD. That's how we think about it. And I know that it's the anterior MI. If I see problems starting from V1 to V4, I know it's the anteroseptal, not just the anterior. As the lead area is becoming bigger from V1 to V4 instead of V2 to V4, V1 area is corresponding towards the septal area, and involvement of the V1 to V4 is giving rise to anteroseptal ischemic area. So still, you know that the septum and the anterior wall is supplied by the lead. So similarly, these are the one. So lead one, AVL, and V5 and V6. These are the lateral chest leads. Remember, these are the lateral chest leads, and it corresponds to the lateral wall infarction and lateral wall of the heart. You can see clearly in the picture that it is supplied by the left circumflex coronary vessel. If you just focus on this picture, you can clearly see that this is the LCX, and it is the one that supplies the lateral wall. LAD supplies the septum and the anterior wall. So that's how the ECG changes are predictable, and ECG changes, they love to ask you about the ECG changes. Okay, so the concept is that each vessel supplies a specific area, and each area is producing changes in specific leads of the ECG. And so they can ask reciprocal questions. They can ask you, okay, we see changes in these two leads, V4 to V2 to V4. Tell me which vessel is being involved. It's the LAD. Or they may ask you, okay, we saw that LAD is included. Which ECG leads we are going to see the changes most? So remember, these are the V2. So these are the reciprocal type of questions they ask you regarding the ischemia. Okay. So stroke volume. Who knows about the stroke volume? Naman bhai, what is stroke volume?
Stroke volume is the amount of blood that is pumped out in every contraction.
Okay, so stroke volume is the amount of blood that is pumped out in one heart contraction. So if that is the stroke volume, so think about it, why we need to have stroke volume. So this is the basic equation to fulfill the requirements of oxygen. We will see this equation later on, but this is the right time to discuss this, because one of the essential component of the oxygen delivery is the heart, and how heart is contributing towards the oxygen delivery. This area of the equation is the heart area. This area of the equation is the lungs area, and this area of the equation is the bone marrow area. So these systems are working together to deliver an adequate amount of oxygen to our body. So cardiac output is a direct predictor of the oxygen delivery. And remember, it's also the vice versa. If you can detect the rate of oxygen consumption, believe me, there is an equation in the market that can allow you to calculate the cardiac output. Just based on the amount of oxygen you are using, you can calculate the cardiac output. And similarly, if so, that's how that is a fixed principle, and we will see that later on, just very shortly. So this equation is so powerful that if you know this the rate of oxygen consumption, you can calculate the cardiac output. So focus on the cardiac output. That is the one that we have to focus during this cardiology section. So cardiac output is the amount of, what is cardiac output?
The amount of blood, or the, what do you call it, that is pumped out in a given amount of time with the heart rate and the stroke volume.
Okay, Ali bhai, what's your definition? He said that amount of blood pumped out in a given amount of time.
Stroke volume, heart rate. So basically, the amount of blood being pumped out with every heart rate, with every pump, basically.
Okay, so the definition of cardiac output is per minute by definition. Never say in a given amount of time. The standard definition of cardiac output is the amount of blood, AB, amount of blood in per minute. Okay, so that's why. So if it is per minute, so we have to calculate the heart rate per minute, and stroke volume, as we discussed, with single beat. It's with single beat. One beat ejects how much volume, that is the stroke volume. So if we are ejecting with each beat 70 ml, and we have 70 heart rate per minute, so that's the so if you calculate 7 to 7, so it becomes 490 ml, 4900 ml per minute, and that's the cardiac output of this person who has stroke volume of 70 per beat, and heart rate of and heart rate of 70 per minute. So his cardiac output becomes 4900 ml per minute. That's the cardiac output. Okay. So what's the definition of cardiac output? It's the amount of blood per minute. What is the definition of stroke volume? It's the amount of blood per beat. Okay. Hello.
Yeah, we're
Yes.
good. We're good.
Good, good, good. Okay, so now the next thing is that how much volume your heart. So this is your the ventricle. So this is the volume that has arrived in the ventricle. So which factors decide how much volume you will eject with every beat? These are the three most important factors that we have to discuss separately: preload, afterload, contractility. Let's focus on the stroke volume. They have not given you the definition of the stroke volume, but I told you it's per beat. Stroke volume is per beat, cardiac output is per minute. So the three factors that affect the stroke volume is the contractility, afterload, and preload. So if we, so do you know why these factors? So what is preload? Ali bhai,
No.
what is preload?
Okay, go.
Oh, preload is going to be the amount of blood that you're basically it's going to be the amount of blood that's going to be in your ventricle before you're pumped,
Yeah, before
before
you
you
contract.
eject it, before you contract.
Before you eject it. Okay. So what is afterload? Anybody
Afterload,
knows?
after you've ejected, it's the amount of blood that is remaining in the ventricle.
Okay. So what about Dr. Naman? What is afterload?
Afterload is the amount of blood that's left after systole. It can be due to maybe like a leakage or something like that.
Okay, so let me tell you about the. Just give me a second. Okay, so we have to open this picture. So let me tell you about these very essential parameters that we have to discuss throughout the cardiology, and these are the one that we have the control over when we are talking about what which parameters we are intervening while we are treating a patient of hypertension, when we are treating a patient of trauma, when we are treating a patient of MI. What are the parameters we are controlling? Look, the parameters are right there in front of you. The first medication that we give to a MI patient is the aspirin. That has nothing to do with these two. But aspirin does not give rise to pain relief. Which first medication give rise to immediate pain relief? That is the nitroglycerin. And that is the one that we right away place under the tongue of a patient who comes with the pain, chest pain, that we think is more likely to be cardiac in origin. So what is nitroglycerin is doing? It is changing the preload. So just telling you this right way, the treatment, that when we are treating a patient, these are the parameters that we change in order to change the functioning of the cardiovascular system. Okay, so that's why they are extremely high yield to understand if you want to go ahead with good knowledge. So preload is the volume coming into the ventricles, and remember, when the volume is what phase of the cardiac cycle the volume comes into the ventricles, systole or the diastole?
Nicely.
Diastole. So end diastolic volume or end diastolic pressure is an indicator of the preload. So never forget this point. If the examiner is telling you end diastolic volume, technically he is telling you about the preload, because preload is not a technical, is not a medical term, and diastolic volume is the true medical term to describe the preload. Okay. Similarly, end diastolic volume or end systolic pressure. These are the great parameters to think about the and describe about the preload. So this is the volume that enters into the heart during the filling phase of the heart, and the filling phase is the diastole. So end diastolic volume or end diastolic pressure is the indicator of preload. So similarly, what is afterload? That's also very high. So afterload is not the volume, first thing. Preload is technically, and through every ways, preload is a volume. But afterload is not a volume. It is this thing. You remember what I'm trying to say?
It's like the resistance. It's like the amount of.
That's the resistance. That's the resistance that the heart is dealing with. Look, the blood that is coming into the heart has the responsibility to push it through the whole circulation, through each capillary. The heart has the responsibility to push it through all the capillaries. That's why heart is beating all the time. Okay, so tell me, if I occlude it 100%, do you think that heart will be able to eject the blood?
No.
If I occlude the vessels, do you think that the heart will be able to eject the blood that it is receiving?
No.
No, never. So why? Because the afterload is very, very high. So it means that the ejection has some inverse relationship to the afterload. So afterload, when it gets high, so what do you think? The cardiac output should increase or decrease?
Decrease.
Decrease. So when the afterload increases, means the resistance at the upper end of the heart increases, the cardiac output will decrease. Similarly, apply this principle here. If you put more blood in the heart, if you put more blood in the heart, what do you think? The cardiac output will be more or less?
It
If
will increase.
the
It
amount of
will
blood
increase.
it has to go out. So if there's more coming in, more has to go out. The cardiac output.
More has to go out. So if the preload increases, the cardiac output will increase. But that's not the case with the afterload. Afterload has inverse relationship. Afterload has inverse relationship. So if you increase the afterload, that becomes a burden for the heart, and it can decrease the cardiac output, and that's how we think of the preload, afterload, and the third thing that is in between these two is the contractility of the heart. And contractility is the ability of the heart to contract. Remember, heart does not have a constant ability to contract. Its contractility can be increased or become decreased. So epinephrine beta 1 stimulators can increase the contractility and the myocardial infarction, and the beta 1 antagonist and calcium channel antagonist, they can decrease the contractility of the heart. Similarly, sympathetic nervous system can increase the contractility of the heart. So remember, contractility, afterload, preload, they are never constant. At every moment, these things are changing. Even when you stand from the sitting position, every parameter change. Every, just if you stand from the sitting position, your afterload changes, your preload changes, and the ability of your heart to contract changes, contractility changes. So throughout the day, these three parameters are changing according to the body positioning, according to the stress level, according to the various other parameters. uh, these levels change, and that's how your whole circulatory system is working. So don't forget these points. So come over here, that stroke volume. If you want to increase the volume with each beat, you have to increase the contractility, you have to increase the blood coming in, and you have to decrease the afterload. That's very conceptual, and that has, I don't think so. A failing heart has less cardiac output. Stroke volume will decrease. Why? Heart is failing due to the death of the myocardial Any confusion till here? The three parameters, and that's the three that we are going to discuss separately, one by one. So come with the heart. So start with the heart itself. So as we discussed, the contractility of the heart is not a is never a constant feature. It changes according to the hormonal nature of the blood, according to the sympathetic nature of the body, and according to the afterload and preload. It changes all the time. So one of the chemical way to change the contractility of the heart is to stimulate the beta 1 receptors of the heart under the influence of norepinephrine and epinephrine. And once these chemicals stimulate the beta 1 receptors on the cardiac cells, this beta 1 receptor will stimulate the alibi. You know that we have discussed these pathways, and you know that The GS system is the one that stimulates the adenylate cyclase. This is the adenylate cyclase enzyme, and you know that adenylate cyclase enzyme is the one that converts ATP into the CAMP, and CAMP is the one that stimulates the protein kinase. You don't need to understand everything right now. The main point here is that when you stimulate the beta 1 receptors due to the epinephrine and norepinephrine, you are going to phosphorylate the calcium channels present on the hard surface, and due to the and phosphorylation, the potassium the calcium channels will open up and calcium will start entering the cardiac cell. And not only the calcium will start entering from outside, instead this protein kinase A will also open up the channels that are present on the sarcoplasmic reticulum. That is the main storage site of the calcium, in intracellular storage site of the calcium. So it will also open up, and the levels of calcium inside the cell will increase to a very high level, and this will ultimately causes the stronger contraction of the heart muscle fibers. Any confusion?
No.
No. So let's move on. The chemicals that you will see in this pathway are less high yield. The mechanism is more high yield. So catecholamines, they come stimulate the beta 1 receptor. What are the catecholamines? Norepinephrine, epinephrine, dopamine, and they phosphorylate the calcium channels. Calcium enter more. And remember, one of a very good mechanism in the heart is that the incoming calcium not only increases the contraction through itself. Instead, it also induces the release of more calcium from the sarcoplasmic reticulum. That is called the calcium-induced calcium release. And when you have more calcium coming inside the cell, more will be stored in the sarcoplasmic reticulum. And the second thing is that we increase the storage by doing the phospholamban phosphorylation. That's a low yield molecule. If you want to memorize it, it's up to you. But just remember that when we phosphorylate this molecule, this phosphorylation of this molecule just activates the calcium ATPase pump here. The way by which we allow the calcium to move from the cytoplasm into the sarcoplasmic reticulum is through this pump, and the name of this pump is the calcium ATPase pump, and this pump gets activated when we phosphorylate the phospholamban, and phospholamban is phosphorylated under the influence of beta 1. So let me make here phospholamban. When it is phosphorylated, then it can stimulate the calcium ATPase pump, and this pump will allow the calcium to enter into the sarcoplasmic reticulum, and this calcium will be stored for the next contraction cycle. Remember that this is a very high, and look at here, the whole phosphorylation things are happening through this protein kinase A. Remember, Ali Bhai, I told you that this is not the time to discuss the protein kinase, what it do, but now you can clearly see what this protein kinase A is doing. This is the protein kinase A. Okay, so this is the time to see how much important affects the protein kinase. Kinase is the enzyme that has the ability to add phosphate groups to other things. So it is adding phosphate group here, it is adding phosphate group here through the phospholamban, and in this way it is leading to very drastic effects. And one of the main way we treat the cardiogenic shock is to stimulate the beta 1 receptors. Remember that dobutamine is a chemical that we have in the market for the patients who suffer from the cardiogenic shock, means whose heart is failing. So remember, the main mechanism through which the dobutamine is going to do this job is through the beta 1 stimulation. We will see this chemical in the heart, the pharmacology of the heart. So increase in the intracellular calcium can increase the contractility, and this is tricky, little bit tricky. But if you just focus on, because you have to understand this mechanism, if you will not, you will be at the risk of losing one or two questions on your exam. One of the pump that your examiners like is the sodium calcium exchanger. And this pump, anybody knows about this pump?
Potassium?
Sodium potassium.
No, sodium calcium exchanger pump.
Sodium calcium exchange.
It pumps calcium out and then sodium in.
And I think this is usually upon like at the end of contraction? Is this the one that they usually use at the end of contraction, which basically allows the muscle to release?
It increases intracellular calcium. Right?
Oh, it's intracellular.
This pump is a bidirectional pump. Remember, this pump only knows that which chemical is high either outside there. For this pump there is outside environment and there is an inside the cell environment. Okay, so if due to some reason sodium increases in the cell, so this pump will start moving sodium out from inside, and while it is bringing out potassium, the positive ions, the next thing it will do is that it will bring in the calcium inside the cell. So if due to any reason you can increase the intracellular sodium, you can ask this pump to put this sodium out, and when it will try to put the sodium out, it will bring the potassium in. Oh, sorry, it will bring the calcium in. And when the calcium will come in, it will increase the contraction, and that is called the inotropy. It's easy. It's easy if you just understand. The opposite will happen if the sodium inside the cell will decrease. It will start bringing sodium from outside, and during that effort, it will release the calcium outside, and that's the one that you are talking about. That's how we do the relaxation of the heart muscle. We put the calcium out, and this is the pump that helps with the relaxation of the myocyte after the contraction. Okay,
So
and this pump. Okay.
So would it be safe to say that the increase in the sodium inside the cell is depolarizing the myocyte?
No, no, it's not about depolarization. This pump has nothing to do with the depolarization. Depolarization is a voltage dependent mechanism.
Okay.
Okay, and this pump has the role after the depolarization. So during depolarization, you know it that so this potassium sodium. So one of the drug that we have in the market is digitalis, and it can block the sodium potassium ATPase, and this pump sodium potassium ATPase takes sodium from inside to outside. So if this pump is blocked, technically we are increasing the levels of sodium in the cell. And once the sodium levels increase in the cell, then what will happen is that this pump will take this sodium out, and during that it will bring the calcium in. And this is the way by which digitalis, a very high yield molecule, just for the sake of mechanism, is very high yield for your exam. Digitalis is not very high yield how it is used. Digitalis is very high yield based on its role on these two very high yield pumps. One is the pump and the other one is the exchanger. So they want you to know this mechanism.
I
Okay,
have
they want you to know this mechanism. Any confusion in the sodium potassium sodium calcium exchanger?
I have a question real quick.
Okay,
It's
very good.
in the first aid. It says digitalis blocks sodium potassium pump, right?
Okay,
So
okay,
increase the sodium inside the cell, correct?
okay,
But then it says digitalis then decreases the sodium calcium exchanger activity. If the sodium
okay.
calcium exchanger activity is decreased, doesn't that mean that that pump cannot pump out the sodium, so it won't bring in any calcium?
No, no, no. Actually, when we after the depolarization, this pump gets activated, and it starts pushing calcium out. Okay, and as we increase the sodium concentration due to the digitalis, so
Right.
this pump will be getting dysfunction. Why? Because this sodium inside the cell will not allow this pump to function in the opposite way. The opposite way is that technically it should bring calcium inside. So if the sodium is more inside, it should take the sodium out and bring the calcium in.
Right.
Okay, so the opposite cannot happen if the sodium levels are high inside the cell. So it's the another way is that after the contraction, this pump was going to take the calcium out. So due to the digitalis, by retaining the sodium, we are blocking the sodium, this exchanger, not to work, so that it is not able to take this calcium out. So these are the two ways to describe the way how we are increasing the calcium inside the cell.
So you're
Either you can
saying,
say that. Mhm.
so you're saying if someone gets the talus, both the sodium and the calcium are going to be high inside.
Definitely, no doubt about it. No doubt. And that high sodium is gonna either change the direction in which this pump will work, or either it will inhibit this pump to don't work. And if this pump will not, if this exchanger will not work, the calcium cannot go out, because this exchanger, when we will do the action potential of the heart, we will see that this is the exchanger that ejects out calcium out of the cell and brings out the relaxation phase. Okay,
So is it safe to
so
say that digitalis blocks and practically both sodium potassium and sodium calcium channel?
definitely,
Or
that's how its direct effect on the sodium potassium ATPase is of no benefit. Its indirect effect on the sodium calcium exchanger is the one that we are looking for. Okay. So the contractility, decreases with the beta 1 blockade, and all this acidosis is the one that I don't tell you, but acidosis damages almost everything. Acidosis don't allow anything to function properly. Similarly, lack of oxygen and calcium channel blockers will also decrease the contractility of the heart. So preload, I told you that it is approximated by the end diastolic volume, and it depends on the venous tone and the circulating blood volume. So have you ever thought about that we have venous tone? What is venous tone? Tell me if your veins are more have more capacity, or arteries have more capacity.
Veins.
ways?
So if due to some reason your veins get dilated, you gave the patient some venodilators. So the veins get too much dilated. Do you think that the blood will go towards the heart more or less?
Less.
Why?
Because it's dilating, so it's going to basically have stasis in those areas.
Or stasis in those areas. So that's the role of venous tone. And the second thing is that if you have less blood in the circulatory system, then less will be the preload. Nothing else. No other third factor affects the preload. The two factors that affect the preload is the venous tone and the circulating volume. If you don't change the circulating volume and you constrict these veins, what do you think the preload will be on the heart?
Then it will increase.
It will increase, because when the veins will constrict, it will push the blood upwards towards the heart. Okay, so that's how the venous dilators, they decrease the preload, and venoconstrictors, they increase the preload. And one of the venoconstrictor of our body is the sympathetic nervous system. So during sympathetic nervous system stimulation, the alpha 1 receptors are getting stimulated, and we will see later on that the alpha 1 are the one that give rise to resistance. Okay, so afterload is little bit more, it needs your attention, so just take a 5 minutes break. We will start later on. Okay.
There's a ton of material.
Yeah. It's just funny. It's like when we read it ourselves, we just read it super quickly.
Yeah, but the thing is, like when you're reading it, it's like you're reading flashcards. It's not like
Yeah.
sentences.
Yeah,
You know,
exactly.
like the other book that we read, the past book,
Yeah,
that's more sentences.
Yeah, that's percent.
I was just thinking that we have to review those leads, the
Yeah,
V1, V2. The past notes have that really good.
yeah, they do. That's true.
Yeah. The way he draws up the
Yeah.
consequences.
Dr. Francis does. Yeah, that's you want something to eat? Did you eat before you came?
If I eat, then I can't pay attention. When blood
I think
supply to the
most of
brain
that stuff is healthy.
increases,
Blood supply.
decreases. There's way too much sugar for me. Like,
The what is it called? The yogurt. It's like Greek yogurt. I have frozen fruit.
you're too healthy for me, bro.
What's that? Are you too healthy for me? You're so funny. I'm trying to eat healthy. I gained like so much weight. It's ridiculous.
I know it's good anyway. I don't know
What are you talking about? Like home?
You're supposed to lose weight before going home,
I
and
know.
then you're supposed to gain about 10 pounds when you go
I
home.
did gain 10 pounds before coming back.
That's a good thing.
It's horrible. That's so much crap for it. My mom's really funny. She's like, तेरा बस exam हो गया फिर देखी मैं तेरे पीछे किस तरह पहनी है.
Oh my
Like
god.
gym में page पे जाऊंगी. I was like, oh my god.
I think I'm gonna go to gym there.
Which gym do you go to?
Leonard Rec Center. It's like $5 a month.
What?
Yeah. I put no, $8.
Oh,
$8.
oh, you had told me about this.
Yeah.
There's like a couple of you had done it together, right?
So, no. It's like they made it new. That like even if you get a loan, it's $8.
Oh, really? Was this the one in Savoy? No.
No, it's right here on Mattis in Champaign.
Oh.
Mattis and Kirby.
Okay, I might want to ask you for that.
Yeah, you could come tonight if you want. All I
Okay.
do is treadmill and like
Okay.
rowing machine.
Okay.
Because I don't want to do too much.
Right.
But I do treadmill for an
I
hour.
feel like I lost everything. It's all like flabby. It's literally feeling like shit. I haven't gone in like that.
I ran 5 miles yesterday and my legs were dead
That's
in the
really
morning.
good.
Like
5
I
miles?
slept like a baby yesterday.
Yeah. What time did you go? You went to the evening?
I usually go in the morning,
Okay.
but today I'm gonna go in the evening.
Okay. Yeah, I kind of like going in the morning too. It kind of gives you all that pump.
Yeah, like blood flow.
Right.
I woke up at 6 o'clock this morning, but then I was like, it's too cold in morning.
Yeah.
It's like negative 1 degrees at 6 o'clock.
Yeah, so you could just look at
It's negative 1 degree Fahrenheit and inside and with the sunshine, like you're sitting inside in the heat and you're like, oh, it's probably 35, 40 degrees.
I have everything in Celsius, right?
Right.
So ever since I came back, I'm just like, actually,
Okay, so probably in Montreal.
yeah,
Montreal.
there was like negative in Celsius.
So afterload, we just discussed what is afterload. You remember what we discussed about the afterload?
Yeah, we said it was the resistance in the vessel, or when we're
In the
trying-
vessels.
in the vessels,
Okay.
right? Or and it's the resistance that we have to overcome in order to get the blood into circulation.
Okay. So do you know where the most of the resistance in the circulation is? Is it the aorta itself or somewhere else?
It
I
is.
think it is the aorta.
Okay. So the resistance vessels of there is a term called resistance. What are the resistance vessels of your body? So remember the resistance vessels of your body are the arterioles.
Arterial.
Okay. This is the arterioles that are the aorta is so big. Okay. So how it can have the highest resistance of the circulation? So it's the arterioles that are the main area. What are arterioles? These are the vessels, the smallest vessels that are just before the capillaries, and they are the one that provide the highest resistance in the circulation. So the heart has to come over the arteriolar resistance so that the blood can be pushed through the capillaries, and then after the capillaries the blood can enter into the venous system. But one very important thing is that when we say the mean arterial pressure or systolic blood pressure or the diastolic pressure, do you think the same pressure exists in the venous system?
No.
Okay, one another very important thing. Tell me, if the resistance is high at the level of arterioles, tell me what would be the pressure after the arterioles? It would be very low after the blood has crossed through this resistance, or it would be very high.
It would be low.
Would be very low. Why? Because already blood has faced so much difficulty to pass through this resistance area, and that very low blood pressure through this capillary system is very important so that the tissues can extract the oxygen and other metabolites and dump their waste materials into the capillaries before the blood can enter into the veins. That's the importance of having very high resistance at the level of arterioles, so that blood slows down to such an extent that for the capillaries it's very easy for the tissues to do anything with the blood, take out something or give out something. So that's one thing. The other thing is, tell me, if this is one vessel and this is the other vessel, through which vessel you need to have more pressure to push blood through?
The bottom one, the one with the big diameter.
Do we need to have more pressure to push blood through this vessel, or do we need more pressure to push blood through this vessel? This is the number one and this is the number two. Which vessel need more force to push blood through it?
The dilated one, number 2.
So do you think that the dilated one is the one that requires more force to push blood through this vessel?
Yes.
Is it logical?
I think so.
No, it's not logical. It's not logical.
Because
The big vessels provide you less resistance, and less resistance, easy flow.
Right, but
That's what I am asking you.
wouldn't the flow be slower through the one that's bigger?
Yeah.
Oh, but this is a diagrammatic picture. In the blood vessels, there's usually not this much change happens when vasoconstriction and vasodilation is happening. It's a very little bit of difference, not this much. This is just a diagrammatic way to describe a concept. You can easily imagine that to push 5 liter blood through this type of vessel is will need more pressure on the heart than to push 5 liter blood through this type of dilated vessel. Just remember, this is a vasoconstricted vessel or this is a vasodilated vessel. That's what I am just trying to say. This much big, of course, there is almost no vessel in your blood that is this much big. Just trying to explain one thing is that so you can assume that the pressure in this system would be high and the pressure in this system would be low. Why? Because the fluid is very easy going. Why it would generate the pressure in the system? So that's why I'm telling you that if the system pressure of the system can tell you about the diameter of that system, can give the information about the resistance of the system. If you have more pressure in some system, you know that the resistance of that system is also high. That's why we need more pressure to push blood through that system. You understand this point?
Yeah.
If the resistance of, again, one more time, this is very fundamental and very important as a equation, if you can understand this. If the pressure of, if the resistance of some system is high, then remember you will have to have more pressure of the fluid if you want that fluid to pass through that high resistance system. Let me explain in the other words. If the pressure of the system is high, I can assume that the resistance of that system is high. That's why I am having a high pressure to be capable of flowing my blood through that high resistance system. So the first line they want to tell you is this, what I just told you. So afterload means the resistance or the load on the heart can be approximated the pressure in the circulation. So if you have less mean arterial pressure, it means the resistance of the vessel is low. And if the pressure of the circulation, mean arterial pressure, is very high, it means the afterload is also high. That these two things they go hand in hand. And one equation that I want to tell you right now is that resistance is directly proportional to pressure. You can never violate this equation. Wherever the fluid, vessel, and some pumping system exist, this is the equation that will be followed anywhere in the universe. Okay, if you have a motor and you have a big pipe and you have two pipes coming out of the motor, believe me, your motor will have much difficult time to push water through this pipe than this pipe. So pressure in this system will be low. Why? Because the motor has very easy way to push blood through this big pipe, and also a lot of space also decreases the pressure of the fluid in this system. But here the motor will also be generating too much force to and also the blood will be, the water will be so much in a narrow compartment. And these two factors, one thing, the motor will generate more force. The second thing, the water will be very concentrated in this small vessel. So these two things will increase the pressure of this. So this equation you can never violate. You can never violate. Resistance is directly proportional to pressure. And that's why the resistance that is approximated by the afterload, and afterload can be approximated by the pressure of the system. Why? We know that these two go hand in hand. Okay, so and another very important example, if I open up all the arterioles, if I open up all the arterioles and we vasodilate, remember the afterload decreases and the mean arterial pressure of the system decreases. If you think that I don't know about this situation, then remember the sepsis. In sepsis, you have so much low afterload that the mean arterial pressure, hypertension, is the hallmark of the septic shock. Why? Because the cytokines that are released in the sepsis, they cause massive vasodilation, and that massive vasodilation decreases the afterload, and that decrease in the afterload decreases the mean arterial pressure, and that's the life-threatening thing that can put the patient to death. This hypertension is the hallmark of the septic shock, and that this line is directly linked to the septic shock. If you want to think about it, that why this is important to think. So afterload. So now, what is the effect of afterload on the heart? Think about it. So afterload will put up pressure on the heart, and that will increase the tension of the wall tension of the heart as per the Laplace law. We will see the Laplace law here. So wall stress is directly proportional to wall tension follows the Laplace law. We will see it later on. So left ventricle complicate. So what do you know what happens when we have too much afterload in the system? Means we have too much resistance in the circulation, and we have to what the heart do?
When you have too much resistance in the system, the heart will have to pump harder in order to overcome that resistance.
Are we talking about
Very good.
resistance in the aorta?
Resistance in the heart or the aorta?
No, a resistance in the circulation. When I say resistance in the circulation, it technically means resistance at the arterial level, because that is the level where the most of the resistance exists in your circulation.
Right. Okay.
So when you have more resistance, the heart will become hypertrophied to overcome that resistance. Okay.
Right.
So what are the arteriolar vasodilators? So arterial vasodilators are hydralazine, and they decrease the afterload. Hydralazine is a very quick acting blood pressure reducer. Look at here. We are reducing the pressure by reducing the afterload. And that's why I'm telling you, don't confuse about this equation. If you decrease the resistance, mean you decrease the afterload, you will decrease the pressure. And that's what hydralazine is doing. Hydralazine will decrease the afterload by causing arteriolar vasodilation. And once you vasodilate, the need for high pressure will be gone, and you will see immediate drop in the pressure of the system. That's what we need. Similarly, ACE inhibitors and ARBs, they are diuretics, antidiuretics. They decrease the preload, but remember that they decrease the levels of angiotensin effect. Angiotensin 2 is a vasoconstrictor. So ACE inhibitors and ARBs will decrease the levels of angiotensin 2, and one of the effect of angiotensin 2 is vasoconstriction. So if you remove the vasoconstriction, the afterload will decrease, and decrease in the afterload can decrease the pressure. That's why these are very, very important antihypertensive drugs. Okay, so the other thing is the chronic hypertension means chronically increased pressure. It will lead to the hypertrophy of the very important thing to understand. If a patient comes to you with dyspnea and other symptoms of the heart failure, and you see signs of left ventricular hypertrophy, you know the patient is suffering from the hypertension. Heart failure symptoms plus signs of left ventricular hypertrophy. Even before measuring the blood pressure, I can assume that this patient is suffering from too much afterload. Why? Because that is the situation where your left ventricle hypertrophies. Very, very important thing to note. Okay, so myocardial oxygen demand. Now, all these factors are affecting the myocardial oxygen demand, increasing contractility, afterload, heart rate, diameter. Now, this is something that you may confuse, but this is also very low yield thing. I have never seen any question targeting the increased diameter of the ventricles. So if you just imagine heart in your mind, so you can think that if the heart becomes from this to this, then you can clearly imagine that the stress wall tension on the heart muscle wall will be more, and that is called, that will increase the increasing the diameter of the ventricle will increase the wall tension. And once the wall tension increases, the heart muscle need more oxygen, and that more oxygen will be increasing the myocardial oxygen demand. So wall tension follows the Laplace law. Wall tension is directly proportional to how much pressure this wall of the ventricle is already experiencing, and the second thing is that how much tension this wall of the heart already has. So one thing is the pressure from the fluid that is attacking on the wall of the heart, and the second thing is the actual diameter of the heart that is also contributing to the tension on this wall. So that is measured by the radius. So pressure and radius, in pressure in the ventricle and radius of the ventricle, they calculate the wall tension, and wall tension is directly proportional to the myocardial oxygen demand. So wall stress leads to wall stress is directly proportional to the pressure, directly proportional to the radius, but inversely proportional to the thickness. If your heart becomes thick, then the wall stress decreases, and when the wall stress decreases, the myocardial oxygen demand can decrease because additional muscle fibers that are being made in the wall of the heart, they may share the stress. So if you have more wall thickness or thick fibers, then they can share the stress, and overall the stress of the ventricles will decrease. Low yield thing. This Laplace law thing is low yield thing, but these three things are very high yield things. If you understood this thing, then okay. Otherwise, it's not of much clinical importance. So we discussed that stroke volume is and diastolic volume minus this and systolic volume. So what is the answer? That's end systolic volume.
The, the volume that remains after contraction.
Okay, very good. So the difference of the volume that enters minus the volume that left in the heart after the contraction means the remaining volume we ejected out of the heart, and that is the definition of the stroke volume. So this is the true calculated definition. This is one we can calculate through the echocardiography. Remember, we can calculate the stroke volume, and this is the volume that we have to document while we are doing the echocardiography. Not only the stroke volume we have to document, we also have to document the ejection fraction of the patient. So how we calculate that? We calculate the end diastolic volume, then the end systolic volume, and then we subtract it, and that is the stroke volume. So the next thing is the ejection fraction. Ejection fraction is also calculated from, once you calculate the stroke volume and you know the end diastolic volume, you can easily calculate the ejection fraction. So what is the ejection fraction? What do you think about the ejection fraction?
The ejection fraction, I think, is going to be
Physical means, tell me, oh, ejection fraction means this.
fraction is going to be basically in comparison to the amount of blood that is coming to the left ventricle and how much is leaving. So you're basically comparing those two values.
It is
Very
like that
Mhm.
came in,
Yeah.
and then the afterload that went out, and what was the difference between them? Like the fraction that's left over after the ejection.
Is ejection fraction what's left over or what's gone out?
Ejection fraction is the percentage of the blood,
That has gone out.
percentage of the blood that went out. Believe me, people often confuse this thing. They often take the ejection fraction in absolute words. Remember, we always give the ejection fraction as 65%. Maybe this person is a normal. This person is a normal person, or it can have some abnormality.
Okay.
If I say a person has 65% ejection fraction, it means that its heart is fully functional, or there can be some abnormality in this heart with this normal ejection fraction.
I think there could be an abnormality because I think if the heart is hypertrophy, it will eject high, right? It will have a high ejection fraction, but there is a pathology involved.
Which pathology?
If it's hypertrophied,
Okay, why hypertrophied heart will have high ejection fraction? Why?
because your contraction is strong, so it's actually going to empty out the heart.
Okay, I understood what you are trying to say, but that's not the case that happens in the in the real world. So remember that 65% means, so whatever, so in the 100 ml volume that was the end diastolic volume, we ejected out 65 ml. So this is the 65% ejection fraction. So tell me, if I say only 10 ml was able to enter into the blood and only 6.5 was able to go out, so tell me what will be the ejection fraction of this system?
65%.
65%. So this is the normal ability of the heart to relax and allow the blood to enter into the heart. And this is the second heart which has so much stiff walls that it does not allow the normal amount of the heart of the blood to enter into it, and the ejection the stroke volume is less. But if you compare according to the ejection fraction is high. So this is the diastolic heart failure, and that is the heart failure we call heart failure with preserved ejection fraction. So never ever ever never understand that the ejection fraction is never take ejection fraction in absolute mLs. Ejection fraction is always a percentage. That percentage could be normal, but it could be normal in the heart failure due to the diastolic dysfunction. And yes, Alibai, if you have told me that a hypertrophied heart will not allow the blood to enter into it because it has difficulty in relaxing, and maybe the cavity of the left ventricle has shortened due to that hypertrophy, then I would be said you are right. But you related the hypertrophy with the ability to contract more. Remember, when the hypertrophied patients really come to the clinic, their contractility has dropped. That's why they have come to the clinic. If their contractility was so high, that's the time when the heart failure was in the compensated state. Usually these patients come to the clinic when they get deteriorated, when their heart failure starts getting worse, and that's the time where their contractility starts dropping down. So the only two scenarios that you have to think about with the normal ejection fraction is either it is truly normal, and either it can be due to the heart failure due to diastolic dysfunction, because that's the scenario where the heart will not allow the blood to enter into the. So this is the cardiac output. I showed you the equation before, and I tell you that when I showed you that equation, you remember I showed you the equation of oxygen delivery. And from that equation, I showed you that just knowing the rate of oxygen consumption, we can calculate the heart rate or the cardiac output of a person, and that is the Fick principle. And there is a one question in U world, and if you know this equation, if you memorize this equation, you can easily answer that question. In that question, the U world is trying to ask which three parameters you need to calculate the cardiac output according to the Fick principle. So these are three parameters that you need. You need to have rate of oxygen consumption. You need to have how much was present in the arterial oxygen and how much was the venous oxygen. So you have to subtract them. They will never let you calculate this one. They just try to ask you that the rate of oxygen consumption, and this question can help you, and this is directly linked to that oxygen delivery equation, that how important the oxygen delivery and cardiac output are related. If you know one thing, you can calculate the other thing. Just from the oxygen delivery, we can calculate the cardiac output. So that's very high yield. So just knowing the oxygen consumption and oxygen contents, you can calculate the cardiac output, very high yield. So some exercise affects the heart rate initially and stroke volume, but in the later stages of the exercise, your cardiac output will be maintained mainly by the increase of the heart rate, nothing else. So stroke volume will not increase in the later phase stages of the heart rate. Maybe the heart rate will in the later stages of exercise, the stroke volume will not keep increasing, but the heart rate can still increase to a certain limit. But even after few moments of the exercise, even the heart rate will not be able to go further, because the maximum heart rate that you can achieve, do you know what is that?
220 minus your age.
What you said?
220 minus your age. Isn't that correct?
Yes, that's the maximum heart rate that you can achieve. So if you keep on exercising and you have reached that limit, you will not increase further. So pulse pressure, anybody knows about the pulse pressure? What is the pulse pressure?
Not
That's
know.
per pulse, like per beat or something. I'm not sure.
That's stroke volume. Right? Oh,
Yeah,
well, volume
the
per beat.
volume. Not sure.
Okay, let me show you one picture so that you can visualize what pulse pressure is.
It is right there.
Remember the fluid, wherever the fluid and vessel is, a compliant vessel is, whenever you have a new wave of fluid entering the that compliant vessel, you will lift the wall of that of your vessel, and that is exhibited physically as a pulse. That's why we can easily measure the pulse, and that pulse can go away if the amount of pressure that is getting generated in this the vessel system is very low. If your systolic pressure keeps decreasing, maybe the pressure will become so low that we will not appreciate any pulse. So this is one of the cardiac cycle. This is a one cardiac cycle, and in this cardiac cycle, your ventricles are contracting and they are ejecting the blood. Your ventricles are contracting and ejecting the blood and reaching this peak point, and that is the point that is measured as the systolic blood pressure. And after this systole, the relaxation phase starts, and your ventricles reach a nadir, and that nadir is the diastolic pressure. The difference of these two pressures is the pulse pressure. Okay, the systolic pressure minus the diastolic pressure is the pulse pressure. That's simple. So systolic pressure minus the diastolic pressure is the pulse pressure. Tell me, if I eject more blood in the aorta and the vessels, what would be the systolic blood pressure? It would be more or less?
If you inject more blood into the circulation,
Yes.
so the systolic pressure would be more.
So if this is more, then overall difference of this equation would be high. So remember that as you increase the stroke volume, the most important definition that regarding the pulse pressure I want to give you is that the pulse pressure is directly proportional to the stroke volume. You increase the stroke volume, you are increasing the cardiac output, and you are increasing the systolic blood pressure, because that's how you stroke increase in the stroke volume can happen through increase in the contractility. That's the most common way, and that increase in the contractility that is giving rise to increased stroke volume will ultimately increase the systolic blood pressure. So if you remember this equation, that would be very, very great for you, because this equation is very important. So clinically, in a patient that is hospitalized after some surgery, and suddenly the pulse pressure drops down, believe me, my right away my focus would be that this patient might have some myocardial infarction and lost the ability of contractility, lost the stroke volume, decreased the stroke volume, and once the stroke volume decreased, the pulse pressure decreased. So that's how we think about it. So the other thing is that the arterial compliance is inversely related to the pulse pressure. So tell me, if this is a vessel, and if we try to push blood through it, and it quickly opens up, do you think that the pressure in this vessel will build or it will dissipate?
So it's a lot less now.
It allowed less. Why? Because as soon as we push the fluid in this chamber dilated. So as soon as this chamber will dilate, so according to the Boyle's law, the pressure is inversely proportional to the volume. If you increase the volume, the pressure decreases, and if you decrease the volume, the pressure increases. So a compliant vessel can easily increase the volume. So if a compliant vessel will easily increase the volume and will not allow, according to Boyle's law, increase in the volume of a compliant vessel will decrease the pressure, and that pressure is the pulse pressure. So pulse pressure is directly proportional to the stroke volume and is inversely proportional to the arterial compliance. If a artery is very compliant, then remember that maybe if a artery becomes 100% compliant, maybe we will never feel the pulse. Okay, so a very compliant vessel will never allow the build up of pressure in that vessel. So if we are feeling the pulse, why? Because our vessels are not 100% compliant. They have the compliance, but not that much that we cannot feel the pulse. So stroke volume. So arterial compliance is not clinically important. Why? Because this is not changed. This is a intrinsic property of the vessel's structure. The thing that can change very acutely is the stroke volume. If due to acute myocardial regurgitation after the MR, patient came to you with myocardial infarction, and initially there was no murmur on the physical examination, but when we will do the mechanical complications of the myocardial infarction, you will see that after 3 4 5 days we can develop the infarction of the papillary muscles. So that infarction of the papillary muscles can give rise to acute myocardial regurgitation. So due to that acute myocardial regurgitation, the stroke volume will be very less, the practical stroke volume. I'm not talking about the total ejection. The ejection would be high, but major blood will go to the left atrium instead of going to the aorta. So stroke volume will suddenly decrease and the patient's pulse pressure will be very low. So that's how this is the thing that can change very acutely in various circumstances. So arterial compliance does not change day to day. It is the intrinsic property of the vessels that is there and stays there for years and years. But the stroke volume, it is the one that we are looking for, whether it is changed in a person due to some reason, either due to MI, either due to acute myocardial regurgitation, or either due to the progressive heart failure. The stroke volume will be keep decreasing. So pulse pressure increases in some conditions and decreases in some conditions. So these are the conditions. Usually it increases the contractility, aortic regurgitation. We will discuss why the pulse pressure increases in the aortic regurgitation. Why? Because in aortic regurgitation, when we push blood into the aorta, much of the blood goes back into the left ventricle. So in the next beat, that blood plus the new venous return will be ejected out in the next beat, and that next beat would be having so much stroke volume, and that's why the pulse pressure is very high in the aortic regurgitation. So the aortic stiffening, if the aorta is stiff, what do you think? So stiff aorta, just give me a second, please. So that's the case where we stiff aorta has less compliance. Less compliance, it means more pressure. Okay.
Question. So when you put your hand on your chest and you feel that the heart is beating really hard, so that means that there is like a lot more feeling of the heart wall that's coming out of your chest. Does that mean there is more pulse pressure?
No, that does not mean. The pulse pressure is the technical and mechanical definition, and the definition of the pulse pressure is this. And one of the physical signs of the high pulse pressure we will see in the when we will discuss the aortic regurgitation. I will show you that the high pulse, very high pulse pressure, that is very classic of the aortic regurgitation, give rise to physical signs. You will see bounding pulses, Just feeling the heart beating too much does not mean the patient's pulse pressure is high. It can, but it cannot. But feeling of the heartbeat is not a specific indicator of high blood pressure, high pulse pressure. Okay, maybe if that high beat is due to the hyperthyroidism, maybe patient's pulse pressure is high. But if that high beat is due to the ventricular tachycardia, maybe the pulse pressure will not be high. Okay, so it depends on the clinical situation in which the heart is beating. So that will lead to the pulse pressure interpretation is different according to the situations. So if the aorta is stiff, the compliance of the aorta will be low, and low compliance means high pressure. Why? Because it is inversely linked. I told you, if this is the heart and this is the thick aorta, do you think that the heart will have to generate more force to push blood through this thick aorta, or less force to push blood through this thick aorta?
The
Well,
thick aorta will need more.
yeah, because the walls are stiff, so they're not compliant, like compliant to the increased volume coming in. So you need
Very good.
more.
Yeah.
Very good, very good. That's the reason. Okay, so when the aorta, so usually when the aorta becomes stiff, we only see isolated hypertension. So, as 80-year-old patient comes to your clinic and when you measure the blood pressure, it's 180/70. This is a patient of isolated aortic stiffening, and that isolated aortic stiffening is giving rise to isolated systolic hypertension. And look at here, the diastolic pressure is. So whenever you see blood pressure issue in a very elderly patient like 80s, usually this is the age they give you on your exam when they want you to focus on the isolated hypertension. So they will ask you what's the reason, and you have to tell that this is due to the aortic stiffening. Okay, so obstructive sleep apnea causes sympathetic tone, and that increased sympathetic tone will increase the not only the contractility of the heart, but also will increase the resistance of the arterioles. And I told you resistance is directly proportional to pressure. Due to this one effect, and the second effect is that it will increase the contractility of the heart. So due to these two effects, the systolic blood pressure of the heart will increase and the pulse pressure will increase. So anemia also makes the heart to work more, and that gives rise to more pulse pressure. Similarly, exercise and anemia. These both processes they make your heart to work more and stronger, and that is the increased pulse pressure. So pulse pressure decreases in the aortic stenosis because even though if you generate so much pressure, but if you don't have the outlet to transmit that pressure in the aorta, that pressure will never be transmitted in the vascular system, and that will be calculated as a low pulse pressure, and even the cardiogenic shock, cardiac tamponade, and heart failure. So these are the conditions where the heart is not working, or if the heart is working like the aortic stenosis, but the outlet of the heart is so compressed that the stroke volume is so low in the patient, and so low stroke volume is directly linked uh, to the pulse pressure. Any confusion?
No.
Okay, so that's how we think of the pulse pressure. It's a good indicator towards some of the major pathologies that we have. So mean arterial pressure. So we have three types of blood pressure that we calculate. One is the diastolic, the other one is the systolic, but even more important is the mean arterial pressure. Why? Because systolic blood pressure and diastolic blood pressure, one is high, other is low. Do you think that, and if we stay more at the level of, if you think about the cardiac cycle and you note the timings of the contraction means the systole and timings of the diastole, you will think that the two-thirds of the cardiac cycle is covered by the diastole, and only one-third of the cardiac cycle is having the contraction of the heart. Okay. So the diastole has about 70, 80 blood pressure, and systole has 120. So if two-thirds of the time we are staying in this, so if two-thirds of the day we are staying at this pressure, do you think it's practical for our body to get the blood supply at this level of pressure? No, no. Actually, there is another pressure working in our circulation that is the mean of these two pressures. And when we calculate the mean, it is calculated on equality basis. Means you cannot calculate the mean of the two things who are having different proportions during the cardiac cycle. So we have to take into account the proportion of time during which we stay at a certain pressure level. So only one third of the time we stay at a systolic blood pressure level, and and in two-thirds of the time we stay at the diastolic blood pressure level. If you take a mean of these two, then that's how we calculate the mean arterial pressure at the resting heart rate. Remember, it should be at the resting heart rate. Why? Because when we increase the heart rate, we go more and more towards the systolic pressure. Why? Because when the heart rate is very high, the diastolic time is very low in those people, because when heart contracts a lot of time, uh, the 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 relaxation time of the heart is decreased, and more time we are in the systolic phases. So that's why they are telling you that it should be the equation to calculate mean arterial pressure during a resting heart rate is 2 by 3 diastolic blood pressure plus 1 by 3 systolic blood pressure. So another thing that I always told you, pressure is directly proportional to resistance. So this is the equation. This is the mean arterial pressure. This is the resistance. So this same principle is also applying to here. What does it mean? If you have more resistance in your circulation, believe me, you have to have more pressure if you want your blood to reach the your vital organs. Okay. So if you have more resistance in your circulatory system, you will need to have more mean arterial pressure, high mean arterial pressure, if you want the blood to go through all that resistance vessels. Similarly, the other way is that if you have low blood pressure and you want the blood to reach the vital organs, you have to increase this mean arterial pressure, otherwise you will die. That's what we do in the septic shock. The primary purpose to in the septic shock is to increase the blood pressure of the patient so that the vital organs get the perfusion. Remember, without perfusion, without pressure, blood cannot reach the organs, and that's the need to have a normal level of pressure all the time in our circulation, so that all our vital organs are getting the enough amount of blood for the existence. So pressure is directly proportional to the resistance, and mean arterial pressure also depends upon the cardiac output. So more and more fluid you are passing through the circulation, more and more pressure you will have. Similarly, more resistance of the system, more pressure in the system. If you understand this equation, we can go ahead. Otherwise, we have to focus on this equation, because this equation is very high yield.
I'm okay with it.
Okay.
Okay.
Ask
If
us,
you have what?
ask us a couple of questions. I think we're okay with it.
Okay, very good. Okay, so there is a concept in the cardiology, and that is the Frank-Starling mechanism. Do any one of you know the Frank-Starling mechanism? Do you think that the preload?
The pressure.
Okay, if you
Oxygen curve.
what?
Are we talking about the oxygen curve? Like how that?
No, I'm talking about the Frank-Starling mechanism.
I don't know.
Okay, so never think that preload has no effect on the heart itself. That's a bad thing to think of. Preload is not just the blood coming into and staying silent. No, it has a very important effect on the heart dynamics. So remember, when the blood is entering into the heart, it can change the force with which the heart can contract. So that's the Frank-Starling mechanism. Frank Starling has assessed the various number of volumes entering into the heart. He noticed that when we are in the resting state and we have a normal amount of, means the adequate amount of preload, the heart is functioning at this level. Okay. And in this level, this is the cardiac myocytes, and these crosses are these crosses are are the cross bridges, and these cross bridges decide the strength of contraction. The more the number of cross bridges between the actin and the myosin, more will be the contraction strength. Okay, and how much these cross bridges will be made between the myosin and the actin, it depends on the stretch on the cardiac muscle fiber. This is a one cardiac muscle fiber under normal and resting conditions. So during that, our heart is working in such a way that the actin and myosin only make two cross bridges, and we get a certain level of contractility. Let me call that contractility C1. Frank Starling observed that when I increased the preload entering into the heart, I noticed that that increased preload put a stretch on the wall of the heart, and when that stretch was produced, the more cross bridges was formed between the actin and the myosin. Look at here, when you will shift this black more towards this area, this whole black will come in front of all these four crosses, and all the four crosses, all the myosin cross bridges, they will be able to interact with the actin. And what do you think? The C2 will be stronger or C1 will be stronger?
E2.
What?
E2.
C2. Okay. So more cross bridges, more between the actin and the myosin, more will be the contraction of the cardiac muscle fiber. So that's the Frank Starling mechanism. What is that? Frank Starling mechanism says that preload increases the contractility, but up to a certain limit. And what is that limit? Remember, the length of the muscle fiber, the stretch on the muscle fiber, that brings the total length in such a way that the, the, the interaction between the actin and myosin is 100% complete. That length of the muscle fiber is called the optimal length of the myocyte. Okay, and remember, when the preload will enter more, the stretch on the myocardial side will increase more. But if you will further increase the stretch on the myocardic cell, what do you think? The number of cross bridges will start decreasing or increasing? If I further stretch this in this direction, means I further increase the preload.
Decrease.
Decrease. Why? Because again, this actin will go away like this, and these cross bridges will start staying empty. So that's the concept of optimal length of the muscle fiber. So normally our myocardium is acting in this way. But if you want to have more blood pressure, if you want to have more cardiac output, you can increase the preload till a certain level of preload at which the cardiac muscle fiber length will be optimal in such a way that all the cross bridges will be occupied, okay, by the actin, and that will lead to a stronger contraction. So what is the Frank Starling? In any, if the cardiac muscle sarcomeres are stretched within limits, mean after that optimal strength, if you will further stretch on the muscle fiber, then that will lead to decrease in the contractility. So that's the concept of optimal length of the muscle fiber. And after that optimal length of the muscle fiber, the contractility will not increase. Instead, it will start decreasing. So if you are within limits, your contractility force will increase. That's the Frank Starling law. And let's focus here. Come to this point and focus here in this picture. This is a normal heart. This is the ventricular end diastolic volume. I told you preload is technically defined in the terms of end diastolic volume or end diastolic pressure. So this is a normal heart. So as you increase the preload uh, as you increase the preload of the heart, you can clearly see that as you increase the preload, you are not staying silent. Your heart is also giving out more cardiac output. And which thing can increase the cardiac output? The only thing that can increase the cardiac output after getting more blood into the heart is when the contractility of the heart also increases with the more and more incoming preload. Only then this increased preload can be ejected out to give rise to more stroke volume and more cardiac output. If the more preload comes and heart continues to contract at the same pace, do you think that we will be able to increase the cardiac output or stroke volume?
If
Hello?
we're, yeah, if we're increasing what?
If we increase the preload in the heart
Yes.
and heart keeps on contracting at the same contraction strength, do you think that we will be able to increase the stroke volume even in the presence of increased preload?
We should be
Yes,
able
we
to
should be.
increase.
It should not be. Why? Because this is the heart. Focus here. We, instead of having one arrow, we have two double preload. Do you think if the contractility of the heart muscle stays still at the same level when it was the single arrow coming into the heart?
Right.
Oh, so
So will you be able to increase the will you be able to increase the cardiac output?
no.
No.
No. So which thing is telling? So with increasing preload, we are increasing the stroke volume. This is an indicator that the contractility of the heart is increasing with the successive increase in the preload. And Frank Starling observed this process, and he made a law, and that is the Frank Starling mechanism. And remember that after, look at here, this is the peak. So we are technically reaching the optimal length here, optimal length of the muscle fiber, and after this optimal length we will start decreasing the, so that's how this is the optimal length where we have the peak contractility, means peak stroke volume. That is an indicator of the peak contractility. And after that, if you will increase the preload, you will see and you will notice a decrease in the contractility. It means that you have exceeded the optimal length of the cardiac muscle fiber after that point. So that's how the Frank Starling mechanism is. Now, what happens during the exercise is that the exercise will cause additional increase in the contractility through sympathetic nervous system activation, catecholamine release, and we saw the beta 1 mechanism so heart failure plus digoxin will also, so you can clearly see that in every situation, even if you are exercising and during that time you are increasing the preload, you are increasing the contractility of the heart. In any condition you are going, look at here, this is a patient with heart failure, and even in this patient of heart failure, increasing the preload is actually increasing the contractility, but after a certain point the contractility starts decreasing. So when we give the patient so this is a patient with just the heart failure, and when we give the digoxin, the contraction strength of the this failed heart increases a little bit. So that's how we think of the relationship between the preload and the stroke volume. And that relationship is an indicator that preload increases the stroke volume by increasing the contractility, and the maximum contractility reaches at the maximum at the optimal length of the fiber. Once you exceed the optimal length of the fiber, your contractility will start decreasing. Even though you have a normal heart, after that optimal length, the contractility will start decreasing. If you will put a further stretch on the cardiac fiber, that will decrease the contractility. So it is proportional to the end diastolic length of the muscle fiber. The length of the muscle fiber is very important. Remember that that is how the Frank Starling explained the process of why increase in preload is increasing the contractility. By introducing the idea of optimal length, Frank Starling draw this curve of contractility. So increase these effects can increase the contractility, and these effects can decrease the contractility. We already have seen this in the contractility section. So are you up to for this next thing, or what do you want? This is a little bit dense, and cardiac physiology is fun. Should we start with this? Let's do this resistance at least. Okay.
Let's do this.
Yeah.
Let's do resistance before we discuss the cardiac function curve. So if you will revise all these three things, then these things will become easier. So in any system of vessels, either it is a pipe or actual blood vessel, every system is dealing with the flow that is happening through that pipe. And remember that the property of the pipe is resistance. And remember to allow the blood flow to pass through this resistance pipe, we have to provide P1, and this P1 should be higher than or lower than P2. What do you think?
Yes, that is true.
No, P1 should be higher than P2, or P2 should be higher than P1.
P1 should be higher than.
P1 should be higher than. Nothing else is in this equation. So if I rearrange this, the flow is directly proportional to the delta P and inversely proportional to the radius. So if you increase the difference of pressure between these two endpoints of the vessel, you will increase the flow. And if you decrease the resistance of this blood vessel, you will increase the flow. Nothing else. And when you rearrange this equation can be made that delta P, you bring this, you take this R to this side, and you can clearly make this equation. Delta P is directly proportional to the flow and resistance of the vessel. Again, same story coming again, that pressure is directly proportional to the resistance. This thing we saw in the mean arterial pressure, and this thing again we are seeing in this form of the equation. Actually, this is the basic equation, and let me draw the previous equation that you saw. You saw that the mean arterial pressure is equal to cardiac output multiplied by the TPR. This is what you saw before. Let me show you.
Yep.
Okay, so let me show you. So this was the equation that you saw before, and you may think that this is a new equation that I am seeing. No, nothing else. So mean arterial pressure is directly proportional is equal to cardiac output times the TPR. It's the same equation. This is the principal physical equation from where we derive the dynamics of the fluid. Like the mean arterial pressure means the delta P, the Q is the flow, and that is the cardiac output, and resistance is the TPR in our blood circulation. So according to Ohm law, we saw that the delta V is directly proportional. Oh, it's the same thing. If you apply in the electronics world, the Ohm's equation is also providing you the same concept. So I is the current and R is the radius of the wire, and delta V is the voltage across the wire. So that's Ohm law is actually nothing else but the same equation, that the delta P and delta V and Q is the current and Q is the flow in our blood, and R is the resistance, and resistance is same everywhere. So volumetric flow rate Q is equal to flow velocity and times the cross-sectional area. One of the NBMEs will ask you this equation. When you will do the NBMEs, you will solve one question regarding this equation, and they will give you the velocity, and they will also give you the area. And they want you to remember that Q is equal to velocity times the area. Okay, so that will be the total flow in this area, and that will come that. So don't forget this equation. They can ask you to calculate. They will give you both things. They just want you to know that Q is equal to V multiplied by the radius. Oh, sorry, the cross-sectional area of the okay. Now one more thing I want to show you is the effects of the. So this is a blood vessel, and the resistance we have calculated. How we calculate the resistance of the fluid through when the fluid is passing through the blood vessel. So this is the equation. So radius is directly proportional to the length of the blood vessel and inversely proportional to the radius of the blood vessel. If we have more radius, the resistance would be low, and if we have less radius, means it's vasoconstricted, the resistance would be high. If the length of the blood vessel is more, then the resistance radius will be high. But exam always asks you question. You will see many questions targeting this equation. What is the equation? So if this is the blood vessel, I double the length. So suppose the flow rate is 100, means the flow through this resistance channel is 100 centimeter cube per second. I am going to change the resistance and viscosity of the blood flowing through this blood vessel. If I double the length, so according to this equation, resistance and length is directly linked. So if I make L 2L, so the 100 will reduce to half. That's how we think of the length and its effect on the flow rate. If we double the resistance by doubling the length of the blood vessel, the flow through this blood vessel will reduce to half. Any confusion?
No.
Similarly, viscosity also describes the resistance. Remember, resistance is the total resistance that the fluid is forcing through the facing while it is traveling through this vessel. So viscosity is a feature of the fluid itself. If you double the viscosity, this parameter that is close to the length, just before the length, this is the viscosity of the blood. If I double the viscosity, my flow rate will decrease to half. Now the double the pressure, if that means delta P. If I do, so let me draw a equation for you. Q is equal to delta P and divided by radius. Okay, so if I double the P, so the flow will become double. Okay, so that's what they are telling you. If you increase the pressure, you double the pressure, double the flow rate, and if you double the radius, means if you increase the radius, the resistance will become low. But this is the most common question they ask you. Okay, so if initially the flow is 100, so if I decrease the radius by double, so the radius is equal to now 1 by 2. So you have to take the power of 4 of this 1 by 2, because other things don't have any power. Okay, so 1 by 2 is equal to 1 by 16. Okay, so the flow will increase 100, well, 16 times the flow will increase. So if you multiply 16 with 100, the answer will be 1600. Any confusion? Okay, so that's how we think about it, that if you don't forget that now you know why our body controls the pressure and flow by changing the radius of the blood vessels. The most powerful way to change the flow and change the resistance of the circulation is to cause vasoconstriction and vasodilation. Why? Because you can think of that the double effect on the radius is much important than doubling the length. We cannot change the length. Usually we also don't change the viscosity day to day. The day to day change is actually on the radius through the sympathetic stimulation. Your sympathetic nervous system will vasoconstrict, and that will lead to a change in the pressure of the, because once you change the R, you will change the P. That is a must thing. R and P go hand in hand, and again telling you resistance is directly proportional to pressure. If you increase the resistance of the system, you will increase the pressure of the system. So one last example on this very super high yield equation. What is the treatment of septic shock? What do we give a patient? What?
Digoxin?
The treatment of septic shock is norepinephrine, and believe me, we are giving it to increase the resistance so that the patients who are suffering from hypertension in the septic shock, their blood pressure can increase. The treatment of septic shock is norepinephrine, and the primary purpose to give the norepinephrine is to increase the resistance. And once the norepinephrine will increase the resistance, the pressure of the system will increase, and the perfusion of the the vital organs like brain and other systems will increase. Maybe you have vasoconstriction in the muscles, but due to that resistance, the heart will be forced to contract more. And as the muscular vessels are vasoconstricted, so blood will not go to their muscular beds, but the brain vessels will be the one that will get the most of the blood, and the patient may be saved from that life-threatening hypertension in the septic shower. So don't forget this equation. So resistance is this one, and we discussed this equation. The most high yield parameter here is the 4 power of radius. If the radius doubles 2 times, it means that your blood flow will 2 raised power 4 is equal to 16. So increasing the radius will increase the flow 16 times. And if you decrease the radius by 1/2, means your radius become half, then believe me, your flow will decrease by 16 times. That's the power of radius. And this is one of the equation. I saw one of the question they asked, that series and parallel, that's also very high yield. Why? Because if this is the main trunk, and you have blood vessels arising on its many and many blood vessels arising from its sides, this is called the parallel circulation. And remember, parallel circulation decreases the resistance. It's the one by resistance will decrease, it will decrease. So if you add the if you have blood vessels, and uh, if it is like this is the arteriole, and after that you have another arteriole, and after that you have another arteriole. So here the resistance of this one, resistance of this one, and resistance of this third arteriole, they will get connected to each. They will be added together, and overall the resistance of this single tube that is running all the way, it will have more resistance. So this is the concept of series. So in the series concept, the resistance of every individual component gets additive. Okay, and this is called the total resistance. In the parallel system, the blood has many pathways to flow out, and overall the total resistance of the circulation decreases. One of the question I saw one time, they asked this concept about applying the equation. So they will give you some resistors like this. So tell me, if this is the one scenario, this is the series system, so what would be the resistance of the system, high or low?
Would be
It would be
high.
high. Why? Because all of these resistors are working in line. This is the series system. They are connected in series, so they're the total resistance of the system, RT, is the total resistance of the system, will be the sum of all the individual resistors. But just again, let me explain you that this is the resistor, this is the resistor, and this is the resistor, and this is R1, R2, and R3. This is R3. Tell me, if the blood is coming from here and it has 3 pathways to go, what do you think the resistance of this pathway is, more or less than the previous pathway? This is the number 1 pathway, and this is the number 2 pathway. Whose resistance do you think that is less? The number 2, this is the parallel system, when you have resistors, but they are not attached in series. Instead, we have multiple independent systems through which they flow. Here the blood has 3 pathways to go, and ultimately the total resistance of this system will be low. But if you connect these 3 resistors in series, and blood has to cross all of these in one line, then that would be the series circuit, and in that the resistance is too much. So that's the concept of very low yield thing. But one NVMe I saw that they make you calculate the resistance of the system by giving you they give you a diagram, and when the mother is having a baby inside the uterus, what do you think? That's a in series circuit or a parallel system?
Parallel.
Parallel. So that's why the blood pressure in the mother is a little bit lower. by providing an additional pathway for the blood, you decrease the resistance that is suffered by the blood and you decrease the pressure. That's how they always go hand in hand. So capillaries have the highest area, and pressure gradient drives the flow from high pressure to the low pressure. And remember, arterioles are the one that are most resistant vessels, and veins are the one where most of the blood in our circulation is present. If I check the blood vessels, you will find that majority of the blood of 5 liter blood is present in the veins. Why? Because they are so capacitant. Their walls are very thin and they can easily stretch and they can easily accommodate much of the blood in them. So viscosity is hematocrit based, and in these conditions, multiple myeloma, Waldenstrom, macroglobulinemia, polycythemia, the viscosity increases and the viscosity decreases in anemia. Why? You have less blood cells, and compliance is the delta V over delta P. You may think what is going on here. Let me show you one picture. Cardiology is very fun if you touch it at the base. So this is aorta whose, when I changed this much of pressure in this aorta, I saw this much change in volume happened. But this is another aorta. To get the same change in the volume, I had to change the pressure this much. Okay, hello.
Yeah, yeah.
Yes, yes.
Okay, so this is the aorta that has to give that we have to give so much change in the pressure to bring out the same change in the volume that the previous aorta was having. So the compliance of this aorta is very low. That's why uh, so delta V over delta P is the compliance. If you have the low change in volume and you have very high change in pressure, means delta V over delta P. So this low compliant aorta has too much delta P, and delta V is either normal or still it is decreased, normal to decrease. So that will give rise to less compliance. And this one, the number one has, this one aorta has a normal amount of change in volume with the change in pressure. So tell me, so when the heart starts to contract, the diastolic pressure is 80 and it goes to the 120. So during that change, the volume of the aorta, the aorta also dilates. If it was initially here, so it will become like here when the blood will rush into the aorta under the pressure of the heart. So that's how we have to calculate the compliance. Remember, the most compliant vessel of your body is the aorta. The most compliant blood vessel of your body is the aorta. Okay?
Okay.
Anything here till here. Very extremely pages, extremely high yield pages. If you understand this, then you will know the cardiac pathology. Then you will know the cardiac pharmacology, and all the ischemic diseases of the heart can be explained in whatever I told you. The one addition that I have to give you is the table that which leads give the ischemic indications under when the certain vessel is occluded. If LCX is occluded, what are those leads? If you, I will share these pictures with you. If you can memorize, that's okay. But I have told you already what those leads are conveying the information, and that is very high yield. Because just looking at those leads, you have to tell, oh, this is the LCA that is occluded, this is the LAD occluded, or this is the RCA. Examiners often love to ask you this. This is the thing that we note in patient with chest pain. Okay. So any question till here?
Um, I think we're fine for now.
Yeah, for
We're
now.
gonna review, and if you have any more questions, we'll ask you tomorrow.
Your voice is a little bit getting disrupted.